Dr. Sagar, you are an expert in pulmonary hypertension, is that correct?
Yes.
Would you consider yourself an expert in CTEPH?
Yes.
Thank you. Dr. Sagar, can you give us an overview of the scope of the problem of residual pulmonary hypertension after PTE and after balloon pulmonary angioplasty?
Right, so after we make the diagnosis of CTEPH, we have several options. Prior to surgical intervention, we need to determine if the patient is an operative candidate. If they're inoperable, we have the option of, and strongly should be considering medical therapy. If in fact the patient is operable, then we obviously operate, and if there's evidence for residual disease, we can again consider medical therapy. Another approach in the preoperative setting in inoperable disease is to consider balloon pulmonary angioplasty. And all those options are available for these patients. If you look at the UC San Diego experience, where they actually looked at 2,700 surgeries and published in 2012, and they looked at over a 10-year experience, they actually found that residual pulmonary hypertension was a real issue after surgical intervention. So it wasn't that all these patients who underwent surgery had no residual disease. In fact, over half of them had evidence for some degree of residual disease defined by mean pulmonary artery pressure greater or equal to 25. The long-term outcomes after BPA in CTEPH have also been published, and there's mostly in the Japanese series. And in those patients, you'll also find that the outcomes are fairly decent in terms of long-term survival. But what we're really here to discuss is there is a subset of even those patients that one may consider medical therapy in, for instance, prior to or after BPA.
So are there situations where you would not want to surgically intervene on a CTEPH patient?
Well, I guess I'd break those up into absolute contraindications and sort of relative contraindications. There's very few absolute contraindications since we're offering such a life-changing therapy in terms of an operative intervention. But for instance, obviously if you have inoperable disease, we're not going to be offering the surgery, and that's what we're here to talk about today. If you have severe chronic lung disease, that would be another indication. And of course, if the patient is not interested in the surgery or feels like they're not ready for a surgical intervention, since it is a fairly rigorous surgical intervention.
So what medical therapies, Dr. Sagar, are currently approved to treat CTEPH?
So currently, as was suggested earlier, we really only have one approved medical therapy for the treatment of either inoperable disease or residual disease after surgical intervention, and that is the drug riociguat, where it's been FDA approved. However, there are multiple other pathways, as we know, endothelin receptor antagonists and phosphodiesterase 5 inhibitors, which can also be used and are clinically used today, despite the lack of actual FDA approval, and with, some would argue, clinical efficacy. And the current guidelines suggest that in patients who are post-surgical with residual disease, these drugs should definitely be considered, specifically riociguat. We also may extrapolate from the available data that medical therapy could be woven into the balloon pulmonary angioplasty option, either before balloon pulmonary angioplasty or, for instance, afterwards. And in fact, there's a clinical trial addressing that as we speak.
Thank you. Can you speak to the treatment algorithm in CTEPH?
Right, so the treatment algorithm in CTEPH, which we sort of alluded to earlier, is fairly worked out. Now, lifelong anticoagulation is going to be obviously part of this treatment algorithm, both before the operation as well as after the operation, arguably more important even after the operation. And then targeted medical therapy is a clear part of the algorithm, and it sort of falls again into two potential time points for intervention. One would be in the patient who's inoperable, and also in the patient who's undergone operation and has what we call residual disease and or pulmonary hypertension.
Thank you. Are you aware of any evidence to suggest that medical therapy can benefit patients with residual pH, either after PTE or after BPA?
Right, it's a great question. So there's actually been 4 randomized controlled trials. Obviously the one we just discussed, riociguat, which led to the approval of this medication, which was the CHEST-1 study. And then there's also a sildenafil study, as well as sort of studies that involve the endothelin receptor antagonist, bosentan, which was called the BENEFIT study, and then a more recent study, which was published in the last year, which was called the MERIT study, looking at macitentan. Again, all randomized placebo-controlled trials. In terms of the primary endpoints, in fact, all the studies met their primary endpoint with the exception of the sildenafil study. And the caveat to that statement is that in the BENEFIT study, which had a co-primary endpoint, only the PVR portion of that co-primary endpoint was met. But having said that, these drugs, at least 3 of the 4 studies, seem to have convincing data that medical therapy should be an option in this setting.
Thank you, Dr. Sagar. Can you now speak to some of the evidence for the data on residual and recurrent pulmonary hypertension after PTE?
Yeah, it's a great question. I mean, to answer this question, I think you really have to look at one particular study, since the data here, there's not a lot of data. But if we look at the Canon study that was published in 2016, where they took over 800 patients in the United Kingdom, and actually those were patients who underwent PTE for CTEPH. 64% of those patients were taking at least one pulmonary vasodilator as a bridge to surgery. And following surgical intervention, as expected, there were significant improvements in the hemodynamics and quality of life and functional class and exercise capacity. But despite this, over half the patients actually had residual pulmonary hypertension, defined as a mean pulmonary pressure greater or equal to 25 millimeters of mercury. So I think the point is that there is a significant amount of patients who are felt to be operable, who undergo the operation, and then in fact are rendered with residual disease, where medical therapy should be applied.
Thank you.
The case continues. Dr. Krasuski will now question Dr. Sagar.
Dr. Krasuski, would you like to cross-examine this witness?
Yes, please, Your Honor. So we're going to take a step back. You've told us about the Canon trial and the analysis. Dr. Sagar, could you give us a little bit more information, particularly about those people who develop PH? You said it was 51%. Which of those patients appeared to benefit from therapy?
Well, if you look at the study, over 180 patients out of that over 800 patient cohort were treated with PH-specific therapy in the post-endarterectomy setting with a mean follow-up of just over 4 years. The majority were initiated on this therapy somewhere between 3 and 12 months in their post-endarterectomy period. And a number of factors contributed to why a clinician or a practitioner would initiate therapy in the post-endarterectomy setting. Obviously, these patients were sicker, had higher degrees of residual pulmonary hypertension in the post-endarterectomy setting, or they were functionally doing poorly. They were felt to have residual disease clinically. But to answer your question, when they actually looked at the data and tried to come up with a cutoff for where people, for instance, did worse, for instance, mortality-wise, they actually came up statistically with a cutoff of 38 millimeters of mercury. So anything above or greater or equal to 38 millimeters of mercury in terms of mean pulmonary artery pressure was considered a risk factor for mortality in that setting.
So based on what you've discussed earlier for us, which are the guidelines to treatment of these patients, is that similar to what our cutoff currently is?
Well, no, and I would also argue that while the 38 number is certainly out there, if you actually look at the study in detail, for the patients who had mean pulmonary pressures of greater or equal to 30, although not significant, there was a significant hazard ratio. In fact, even in the conclusion in that article, they comment that perhaps 30 millimeters of mercury seems more conducive to being the cutoff for considering medical therapy in that setting.
So I would just like to point out and summarize that we have evidence in this trial that over 38 looks like it provides a benefit, over 30 may provide a benefit, but that the guidelines state over 25 should be the number that we're focusing on for treatment. So Dr. Sagar, you say that in the guidelines that there are implied recommendations to treat patients post-BPA with PH-specific therapy. The arrow is actually going in that direction, or are you extrapolating? Because we have evidence post-PTE, but can we really apply that to post-BPA?
Well, as we're suggesting, there's a role for medical therapy post-PTE. Perhaps, certainly, I mean, I would argue in all those patients post-PTE with residual pulmonary hypertension. You would argue with a subgroup of those patients. I think there's probably a subgroup of patients who've undergone BPA, where you might consider treating them before the BPA given their abnormal hemodynamics, or even after the BPA.
So you've shown us 4 different trials that examined this particular question of treatment after an intervention. How many of those trials enrolled patients with BPA?
0.
So Dr. Sagar, are you aware of the effect in the CHEST-1 population comparing patients who underwent PTE compared to those that were inoperable as far as the clinical effects of the therapy?
Well, I'm aware there was a subgroup analysis, but the whole group of patients improved. That was how the study was done. So I think that's really the only thing that matters.
I'm done with my witness, or your witness.
That concludes questioning of Dr. Sagar. Please watch the next episode to hear Dr. Valerie McLaughlin take the stand.